Irritability, all right? So this is now a formal FDA term, and it was based directly on the aberrant behavior checklist, irritability subscale. That's where it came from. And so again, for autism itself, maybe ASD now, only children and adolescents ages 5 to 17 essentially for this. Here we go. So medications that we're going to talk about for irritability, antipsychotics and mood stabilizers. Start with antipsychotics. So in the old days, the typicals were studied. Magda Campbell was really the pioneer of psychopharmacology in autism. A number of randomized controlled studies of Haldol and low dose. It can work quite well. It's more likely to result in EPS than some of the atypicals. Here are the atypicals. We know that many of them have prominent effects on serotonin as well as dopamine, as compared with the typicals. A lower risk of dyskinesias, most likely, but a larger risk of weight gain and metabolic side effects. These are the drugs. I didn't get into the newer drugs. I'm too old to even really learn about them and use them, but you're welcome to do that. If you're not going to need too many of them if you've gone through the drugs where there's already data. So this was the first major study by the RUP network, and it was risperidone. This is a pretty good sample size, mainly boys, a 4-to-1 ratio, just like it really is in autism. This is straight autism, and this is the ABC subscale score for irritability, and their score had to be greater than or equal to 18. So these are extremely aggressive children that were coming in. They're on no other medicines. They're only on this. 8 weeks, drug or placebo the whole time. Here's the average age range. This is the final average dose at the end of the study, so relatively low. And this was the dosing range. 70%, this is 69 right here, of the children responded to risperidone for irritability, having to have a greater than or equal to 20% drop in the ABC score and a CGI of much or very much improved. So that's a pretty good rate of response in a controlled study. 12% responded to placebo. I always say that any drugs that don't have side effects don't work. That's a true statement for treating irritability or psychosis. That's positive. At this point, 2013. So then you'd say, well, what are the side effects? Weight gain, it can be a significant side effect with risperidone. This is after 8 weeks. Other side effects, increased appetite, fatigue, drowsiness. These things usually wear off quickly. There was no EPS as measured by the Ames or Simpson-Angus, which looks at akathisia. Those were physician administered over 8 weeks with relatively low dosing. And this is an interesting slide. So this is risperidone before and at the end of 8 weeks, placebo before, end of 8 weeks, and the different subscales of the ABC. So you can see a significant drop in irritability versus placebo. It looks like a significant drop in social impairment compared to placebo, but when we corrected for multiple statistical tests, that went out. Repetitive behavior, better with drug than placebo. And this is really the line that I made the recommendation about risperidone for hyperactivity on, is from this study where you see a significant drop compared to placebo and no significant change in inappropriate speech with statistical correction. So a point here, there's not been yet one drug ever in a decent study to show any change in social withdrawal or impaired communication in autism, the core symptoms, nothing. It's important to remember that and to say that. Here came the, so that's FDA approved. This is now the second FDA approved drug for irritability. This is a small open label study, but it's a little bit interesting because it's in subtypes. 14 weeks open label, 25 subjects, mean age. IQ, a little bit higher range. Same target, irritability. Here's the final mean dose. Starting dose of aripiprazole, strongly recommended, never higher than 2 or 2.5 milligrams a day. Never for anything in intellectual disability, in my opinion. Okay, so this worked really well in this open label study. 84% were much or very much improved. There's the drop in the ABC. Side effects, some sedation, a little bit of EPS, some weight gain. All right, now these are the two larger placebo-controlled studies the indication was based on. Both studies are from the company. There's no independent published large study yet, although we just finished one. So 98 children with autism, irritable, 8 weeks, flexible dosing. So they went up on the dose based on improvement in side effects. This was the final mean dose. It's better than placebo for irritability. These are dropout rates. Side effects, fatigue, sleepiness. This is weight gain. And this is a fixed dose study where you see they either got placebo the whole time, 5, 10, or 15. So it's forced titration. You have to push it to the highest whether they need it or not, which results in more side effects when you do a fixed dose study. But it's a big study. This is the largest drug study ever published in autism with any drug right now, 218, 8 weeks, different doses. All doses were better than placebo for irritability. These are the dropout rates, AEs, weight gain. Okay. Now these are just the available data with the other atypicals. Those are the only two that are FDA approved. Olanzapine versus Haldol, only 12 kids, 6 weeks, no placebo. These are the doses right here, olanzapine, Haldol. Response, olanzapine, Haldol. The weight gain is pretty impressive. So this is 6 weeks, 9 pounds in 6 weeks here and 3 pounds here with the range. Double blind, Zyprexa, placebo, 11 kids, 8 weeks, dose, response, weight gain again in 8 weeks. Quetiapine or Seroquel, no placebo-controlled studies at all. You see different rates of response, 2 out of 6, 2 out of 9, 8 out of 20, 6 out of 10. Wide variation in dosing. Ziprasidone or Geodon, this is just a retrospective study. Average of 14 weeks of treatment, 12 subjects, a little bit older group. This is the mean final dose. This is when people were being very cautious with the dosing early on. Dosing range, 6 out of 20 did well. No significant weight gain. It's, in my opinion, clinically, this is the only atypical that is not associated with weight gain. It's never been studied in a placebo-controlled manner. This is 6 weeks, open label, 12 subjects, adolescents, mean dose, response, no weight gain. The QTC on the EKG increased, but not to a clinically significant level. Paliperidone, which is a metabolite of risperidone. If you take risperidone, your body turns it into paliperidone, extended release risperidone. And generally, I think of these things as being the same drug repackaged. This one, I'd probably say the same thing, but I'll just say that the results were pretty interesting to me. It was our group, but they were still interesting. 8 weeks, open label, 25 adolescents, young adults. This is real aggression right here. This is real autism. These were people that had been refractory to almost everything else. Final mean dose. 20 out of 24 responded. Typical side effects, some weight gain. But it seemed to work in some people that had had risperidone before and not responded or didn't tolerate it, but that's probably just coincidence. Here's the drop in the ABC score with the paliperidone over 8 weeks. Clozapine, Only case reports in the literature, maybe a total of 30 patients. It can lower the seizure threshold more than the other atypicals, and about a quarter to a third of people with autism will develop seizures at some point in their life. You've got the risk of agranulocytosis, necessitating blood draws, which could be a hassle for everybody involved. Sometimes not. Many of these people have very high pain thresholds, so it may not hurt, but the calamity around it may be distressful. And this is interesting that Dr. Tandon talked about catatonia last night as even a sub-thing of ASDs now, which I wasn't aware of yet. I'll tell a quick little one. I never saw what I thought was catatonia in autism until I moved to Boston a year and a half ago, and I've been doing this 25 years with adults. And so people would write about it, and I couldn't understand what they were talking about. I do believe it is there now. I've seen maybe 3 cases, and it's almost like they're really impaired. It made me frightened. But there was a lot of sort of symmetrical, stereotypic movement that was not standard, and a lot of freezing for hours, difficulty to move them. It was scary. So I've seen 2 or 3 of these now, and I've never started clozapine in my life in 25 years until with one of these guys, because he had everything else that you can imagine, trust me, and nothing helped, and clozapine's saving his life. So I do think there's a small subgroup of people with autism that can develop what may be catatonia, but I think it's tricky, and I'd worry that it's going to get overused as a specifier. But on the other hand, I think there are cases. So that's one reason I just sort of list it here, is based on very limited clinical experience. Okay, that's the antipsychotics. Mood stabilizers. There are no large-scale double-blind studies of any mood stabilizers showing any efficacy for irritability in autism. We could argue about this, but that's the story. I've always tried to use mood stabilizers. I wish they were helpful. I have my residents do it as a learning thing. They may be safer. Routinely, they don't work. They just don't work like an antipsychotic. You could always use them. That's just the data and the clinical experience. So in our clinical experience in a tertiary care autism facility, it's often necessary to administer 2 antipsychotics at the same time. Use of 3 should only be used if one of the 3 is being reduced with the goal of stopping it. So if you've got a couple on board and you want to get some additional symptom control before you start pulling things away because they're doing more than you think they are, you have to have a plan of reducing one while you're introducing the other. So there's never more than 2 on board as a targeted plan. You know, the other thing you see, we talked a bit about this, is you think this drug is doing something but not enough, and you're adding the other one, and then all of a sudden they're like that. They're doing better than they've ever done before, and you don't want to move anytime soon. So that's really how you get into the 2 at the same time. That's probably the main way you get into the 2. It's not as an intention